Welcome to part 2 of Changes Now on Care Delivery Workforce and Provider Payment. In this shorter session, we're going to be taking a close look at managing oral health determinants as they support the concept of value-based care. To recap from our first presentation, health, including oral health, comes from a variety of determinants, not only healthcare. Now, what we do in healthcare is important. First off, we can offer preventive services and we can offer remediation services. We can intercept problems and address them therapeutically. But our counseling and our procedures only go so far, because then the family goes home and the child is cared for day in, day out by the parents who determine what the diet is, what the hygiene is. And therefore, while we're good at educating parents, we're not so good at helping them make changes, particularly amongst the highest risk kids. So let's again take a look at health determinants and consider where to get the best bang for the buck if you're actually trying to improve health rather than simply provide procedures. So most of oral health comes from three factors that are outside of the office. About half of oral health emanates from health behaviors, lifestyle. About 20% from environment, and that's both the built environment, where people live and do they have fluoridation, and are they in safe neighborhoods, and do they have access to grocery stores, and also social environment. Is the family supported by a social network? And then, of course, genetics. With the advent of genomics, there's some beginning notion that we can address people's biology, but by and large, we set this one aside because it is less subject to our intervention. So only about 10% of our own and our patients' oral health comes directly from dental care. It usually only takes a couple of seconds before people stop and say, well, wait a minute, hold on, give me a break. If value-based arrangements reward positive oral health outcomes, and if oral health outcomes rely on what people do day to day, how can we be held responsible for what our patients do or don't do? So that becomes the real question about how we organize care, how we deliver care, how we partner with others in delivering care, and how we segment care, as the Academy has long suggested, according to risk level. Please take a moment to look carefully at this slide as we consider the nature of caries as a disease and how it is that dentistry addresses caries. Importantly, the background to this slide is that dentistry evolved out of the barber-surgeon profession before physicians and surgeons became one profession. As a result, we tend to have a surgical mentality. We tend to look at dental problems as surgical challenges that require repair, rather than concentrating on the underlying nature of the disease. In our case, early childhood caries and caries as it progresses through age is essentially a dietary disease that has a strong hygienic component. And yet we tend to focus our energy on caries prevention in something that we rather glibly call oral hygiene instruction, as though toothbrushing on a regular basis, regardless of diet, would result in the cessation of the caries process. The Academy has made quite clear through the development of its policies and procedures in which they detail care paths according to age, presentation, and parental engagement. And so the Academy has long led thinking that supports value-based care and even alternative payment mechanisms when it suggests that one-size care does not fit all. But in fact, we tend to revert to one-size-fits-all care because we get paid for one-size-fits-all care. The advent of dental insurance standardized the 6-month recall as though every child was at the same level of risk and twice a year was sufficient or not too much, whereas very low-risk kids probably don't need us twice a year, whereas high-risk kids need us to be involved with them on preventive interventions more often than every 6 months. And the lack of payment for risk assessment, the lack of payment for health behavior counseling, this idea that all of prevention fits under something called oral hygiene instruction, which doesn't make any sense when we're dealing with a disease that's primarily dietary rather than hygienic. So in a value-based payment system, care will be tailored to risk level, just like the Academy has long proposed. Dentists will need to reconfigure their practice to address at-risk families holistically so that they can establish, first off, and then maintain healthy oral health and dietary behaviors. Our Academy has taken a close look at value-based care in the context of pediatric dentistry, and they've issued this report called Value-Based Care in Pediatric Dentistry, which I commend to all of you. The executive summary states quite clearly that this is happening on the medical side, but does question the degree to which it will happen on the dental side. But let's take a close look at this second paragraph. The long-standing differences between the dental and medical care systems preclude a simple tag-along as general healthcare system evolves toward value-based care. Dentistry is largely solo or small group practices, different payment systems, separate insurance coverage, and lack of comprehensive electronic health records are just some of the challenges facing value-based care application in dentistry. So one way to look at the future and to prognosticate is to say that these things, the way we're organized, the way we're accustomed to being paid, the way our dental insurance works compared to medical insurance, and the quality of our electronic health records compared to medical health records, all, quote, preclude or challenge or get in the way or prevent or prohibit the adoption of value-based care. However, I'm going to suggest an alternative interpretation, which is that all of those things are true, but that as we are economic animals and we respond to financial incentives, the imposition or the development of value-based care by payers, which is outside of our realm, the implementation of value-based systems by payers will have us reconsider our organization from solo and small groups to larger groups, our acceptance of different payment systems, including alternative payment systems, the nature of our insurance coverage, and the quality of our electronic health records. So this could be a chicken and egg discussion. It could be that these things will keep value-based care from happening in pediatric dentistry. On the flip side, it could be that these things will all change in response to demands by payers. So let's finish up once again with the same set of questions to ask yourself. So given all this new information that you're hearing about with regard to value-based care, how would you respond to a change over the course of your career from being paid for volume, fee-for-service, to being paid for value or some hybrid thereof? How would you address your care content, your staffing, your practice structures, your patient population, and how would you maintain records in a way that supports value-based care? And of course, because this set of materials addresses advocacy, how would you advocate for yourself, your specialty, your profession, your patients, and their family?